to the next lecture of general embryology, in which we are going to discuss the decidua, what is form, how the formation of the chorion and amnion is happening. So, chorionic cavity, amniotic cavity, then amniocentesis, chorionic villi biopsy, then trophoblast. So, these are the general topics which we are going to discuss in this lecture. So, decidua, first we will discuss that. Now, after the implantation of the embryo, the uterine endometrium is called as decidua. When morula reaches the uterus, the endometrium is in the secretory phase. After the implantation, features of the endometrium seen during secretory phase are maintained and intensified. The stromal cells enlarge, become vacuolated, and store glycogen and lipids. This change in the stromal cell is called as decidual reaction. Now, the portion of the decidua where the placenta is to be formed deep to the blastocyst is called as decidua basalis. So, this is decidua basalis. The part of the decidua which separates the embryo from the uterine cavity, this is known as the decidua capsularis. And the part lining the rest of the uterine cavity is given the name decidua parietalis. Now, coming to this coronal section. So, this is decidua basalis, this is blastocyst, this is decidua capsularis, and this is decidua parietalis. So this is uterine cavity. So this is the horizontal section and this is the coronal section of the uterus with the implanted blastocyst. Now, the changes happening in the decidua basalis is part of the decidua forms the maternal component of the placenta. As the chorionic villi invade the decidua basalis, they form wedge-shaped area of the decidual tissue called placental septi. Now you can see here. So this is the maternal side in which the decidua basalis is there. So when the chorionic villi they invade the decidua basalis, so they form wedge-shaped area of the decidual tissue called as the placental septi. Now septi divide the fetal part of the placenta into a convex area called as cotyledon. Each cotyledon contains about 2 to 3 chorionic villi. Then between the villi is the intervillar space bounded by the chorionic plate on the fetal side. So this is the chorionic plate, and decidua basalis on the maternal side, which we call it as a basal plate. Now coming to the formation of the chorion and amnion. Chorion and amnion are the fetal membranes and play an important role in childbirth, that is parturition. Now coming to this amnion. Amniogenic cell plus the visceral or subplanchnopluric mesoderm, they form the amnion, you can see here. Because we know that extraembryonic coelom, it divides the extraembryonic mesoderm into two layers, that is somatopluric and subplanchnopluric. Now this subplanchnopluric mesoderm and the amniogenic cells, they are going to form the amnion. Now coming to the formation of the amniotic cavity, the space appear between the epiblast and the trophoblast, forming the amniotic cavity filled with amniotic fluid. The roof of the amniotic cavity is formed by the amniogenic cells which are derived from the trophoblast, while epiblast form its floor. So this is the amniotic cavity. Now during late embryonic period, this cavity expands due to the accumulation of the amniotic fluid. Now the amniotic cavity expands on the expense of extraembryonic coelom. Coming to the amniotic fluid, the source of the amniotic fluid is it is clear and watery fluid derived from the maternal plasma. Some amount is also secreted by amniogenic cells. So when fetal kidney becomes functional, fetal urine also contribute to this. So these are the sources of the amniotic fluid. Now basically what is this amniotic fluid? This is clear watery, that is 98% of this fluid is the content is water and contain 2% solids, inorganic salts, urea, protein and sugar. So amount is about 10 to 20th week, the amount is about 25 to 400 ml. At 28 weeks it is 800 ml, and at terms it is 1000 ml. In post maturity beyond 40 weeks it is reduced to 400 ml. Now functions are basically this amniotic fluid, it supports the embryo, protecting against injury. Now if we see the clinical correlation of this amniotic fluid, the polyhydroamnios is more than 2 liters of amniotic fluid. When it is present, we call it as polyhydroamnios. Then oligohydroamnios is scanty amount amniotic fluid. Then third clinical correlation related with this is amniocentesis. So circulation of the amniotic fluid is later during pregnancy. Fetus swallows amniotic fluid. Now what happened next to it? Reabsorbed from the fetal intestine. Then it enters the fetal blood stream. Then it get filtered from the fetal kidneys and excreted as fetal urine. So by 36 weeks of pregnancy, around 1 liter of amniotic fluid is present. Now coming to the before coming to the amniocentesis, so prenatal diagnosis of the fetus is it involves a testing the fetus for genetic, chromosomal and structural abnormalities before birth. Now various methods are ultrasound imaging, amniocentesis, chorionic villus sampling, fetal MRI and maternal screening. These techniques help it in detecting the congenital anomalies and guide clinical management and counseling for the prospective patients. Now coming to this amniocentesis, this is one of the prenatal diagnosis. So the collection of the amniotic fluid is done. Fluid is either collected through cervix or anterior abdominal wall, usually done during 15 to 20th weeks of pregnancy. About 20 ml of amount of amniotic fluid withdrawn into the syringe. So this is the procedure how it is removed. Now, what are the indication of amniocentesis? First is the genetic and chromosomal testing. So, advanced maternal age over 35 years, then family history of genetic disorder. Then, second is the assessment of fetal health, detection of neural tube defects, evaluation of the fetal lung maturity, and diagnosis of fetal infection. Third is evaluation of pregnancy complication. So, polyhydramnios or oligohydramnios. So, why it is happening? So, for that, the amniocentesis sometime is done. Monitoring in pregnancies with multiple gestations. Now, what are the complications of this procedure? Miscarriage can happen, infection can occur, leakage of amniotic fluid can be there, then risk of needle injury to the fetus is there. Coming to this small topic that is trophoblast, we know it. This is blastocyst when it invades the uterine endometrium. This is the polar trophoblast. This is a mural trophoblast opposite to that. We have discussed it in our previous lectures. So trophoblast, it is the first embryonic membrane. Initially, it is the outer cell layer of the morula. In blastocyst, the trophoblast cells are flattened. So this is the procedure, how it is changed, how it is formed. The part of the trophoblast is in contact with the embryoblast is called as polar trophoblast, and remaining trophoblast lining the wall of the blastocyst is given the name mural trophoblast. It will give rise to placenta, which provides nutrition to the embryo. Initially it is a single layer and later on become bilaminar. So what are those two layers of the trophoblast? That is in situ trophoblast and cytotrophoblast. Then later on it is going to contribute to the formation of the chorion and chorionic villi. Coming to this chorion, made up of parietal or somatopleuric extraembryonic mesoderm and overlying trophoblast. You can see here. Extraembryonic coelom becomes chorionic cavity in which the developing embryo, amniotic cavity and yolk sac is suspended by the connecting stalk. Blood vessels developing in extraembryonic mesoderm becomes chorionic vessels. Coming to chorionic villi. Chorionic villi they develop from chorion. So this is the chorion. From these structures the villi they develop. We call it them as chorionic villi. These villi are the functional elements of the placenta. Villi are offshoots from the trophoblastic surface of the chorion. You can see here, this is the trophoblast. So these are the offshoot coming out from that. Villi are surrounded by maternal blood, and inside the villi capillaries circulate the fetal blood. Now what are the types of chorionic villi? Chorionic villi are first formed all over the trophoblast growing into the decidua. You can see here. The chorionic villi, that is villi related to the decidua capsularis. So this is decidua capsularis. They are transitory. So these villi are transitory and degenerate after some time. The part of the chorion becomes smooth and we call it as chorion villi. It regresses in third month of pregnancy. Next is chorionic frondosum. Villi related to the decidua basalis undergo considerable growth. Along with the tissues of the decidua basalis, the villi form a disc-shaped mass called as placenta. The part of the chorion that helps to form the placenta is called as chorion frondosum. This is how it is happening. This is decidua basalis, this is chorionic frondosum, this is chorionic villi, Decidua capsularis is there, then Decidua paritalis is there. This is uterine cavity. With further growth, there is fusion of the Decidua paritalis, chorion levi, and amnion. Now it is all around surrounded. This fetus is all around surrounded by the amniotic cavity, and this is the site of the formation of the placenta. Chorionic villi formation has three stages. Primary villi, the central core of cytotrophoblast, covered by layer of syncytial trophoblast. Adjoining villi are separated by the intervillous space. Secondary villi has three layers, inner to outer, extraembryonic mesoderm, then cytotrophoblast, then syncytiotrophoblast. So this is secondary villi. Tertiary villi has three layers as secondary villi, but in the there is blood vessels, blood capillaries are there in the mesoderm. So these are the three stages of chorionic villi. Chorion villus biopsy. Biopsy of the chorionic villi is taken either by abdominal route or by cervical route. The procedure is performed between 10 to 12 weeks of gestation. These are the indications. Chorionic villus sampling is offered to the pregnant women who have an increased risk of fetal chromosomal or genetic abnormalities. So these are the risks, that is increased risk of abnormality identified through antenatal screening, a previous child with chromosomal or genetic abnormality, known carrier status for a genetic condition, a family history of genetic condition, ultrasound scan, evidence of fetal abnormality that are associated with a chromosomal or genetic condition. So these are the disadvantages. Miscarriage can happen, vaginal bleeding can be there. Then other maternal complications include pain, infection, amniotic fluid leakage. So this is all about today's lecture. Thank you very much.